Okay. Okay. Ladies and gentlemen, welcome to this themed session on patient participation. We've got two separate speakers today, and I'm going to let each of them, two separate sets of speakers, I should say. I'm going to let each of them introduce themselves and run their session, and then we'll keep all the questions till the end, and I hope we'll have a really good discussion with all four speakers. So I will hand over straight away to our colleagues from Edinburgh and from Padua.
Thank you very much. Thank you very much, Jane. Thank you very much to all of you to be here. It's a pleasure for us to have a discussion, may I say, even if it's a little difficult because of the room, but I really hope we can share some experience. I am Piera Poletti. I am from Italy. I live in Padova. I work in a center for research and advanced education, and I work in quality improvement and patient safety, especially with patient and professional involvement. I work in some program, also in the institution, but mainly on research, and I am going to present a couple of my experience with research. And Andy?
Hello, hope you can all hear me. Yes, if you wave your hand at the back. Yeah, okay. Hello. I'm Andy Thompson. I'm an academic in political science at the University of Edinburgh and worked for many years on particularly looking at the patient's perspectives of healthcare. Piera and I have worked together for many years, coming to many forums, and this one is based on trying to understand how we can connect different methods. And because of the limitations of time we found ourselves in, we've decided to focus mainly on what I'm going to present, but it's no sign of Piera's lack of contribution, which you will see in a couple of slides towards the end. So bear with us. Okay.
We can just ask them if they are clinicians. May we kindly ask if there are patients in the room? Okay, thank you. Can we ask how many of you are clinicians working on the field? Okay. Thank you. And do we have a CEO or people in the administration? Thank you. And do we have people just in the quality services or patient safety services? Okay. Do we have academic? Okay. And I hope to have mentioned all the categories. If I miss someone, please apologize. Thank you very much. And
okay. Thank you very much. What I said is we're going to talk about mixed methods, but obviously we need to think about what are mixed methods, and I'm not going to spend a lot of time trying to define them, but it's generally understood, if you look in the literature, as being a combination of qualitative and quantitative methods, both trying to understand the same issues that we're focusing on. If you say, well, I'm doing two different types of qualitative methods, that's usually known as multi-methods, but I don't think we need to worry about getting into the semantics. The essential advantages of mixed methods are seen that we can, by combining different methods, we can complement and strengthen each method and hopefully mitigate the weaknesses which are inherent in every single method we use. Of course, the disadvantages are, first of all, how do you combine these different methods effectively, rather than just piling all the data together and saying, I'm sure it'll make sense in the end. And the more fundamental issue about the different philosophical positions that are taken or sometimes not recognized about what exists and how we can know it. I'll come back to that issue shortly. There are many different purposes put forward, but I particularly find this set of 5 purposes the most useful. Alan Bryman, I think, has as many as 21 in his list, but it becomes a bit difficult to see the wood for the trees, as we say. These 5, then, first of all, just by putting different methods together doesn't mean to say you're triangulating the data. I think this is a common mistake, although people may disagree about definitions. Triangulation is when you're using different methods to try and increase the validity by showing to what extent these different methods corroborate each other. There is also another method which is what is known as complementarity, which is where you're trying to use one method to enhance the understanding given by the other method, or trying to use it to explain why you have the results you have from one method. And this is a particularly useful way of thinking about it. Another very commonly used approach is the developmental route, which is to say that we use one method to inform how you might then develop and use another method. I'll give you an example in a minute. Another one which is very rarely used as a strategy is what's called the initiation, where you're deliberately seeking contradiction between methods, or the results from different methods, and trying to give new interpretations. My own view of this, and you may disagree, is that that should always be available to you when you're trying to put methods together, because very often you do find things which don't seem to fit together somehow, and it creates an interesting opportunity for trying to understand why not. And the last one is what's known as expansion, where you take one method and then you develop with another method the breadth of study and potentially the depth of the inquiry you're making. So, how can we mix methods? Well, very briefly, there are different ways we can do this. Given that we're working with qualitative and quantitative methods, is we can use qualitative methods first as a basis for then developing our quantitative measures. So, for example, if I want to know what patients are thinking about a particular service, the quality of it, I might start with interviews, focus groups, storyboards, whatever you might use, to identify what are the issues, and then defining the variables, as we tend to talk about in measurement terms, that come from that. Allowing us to understand those processes, the patient journey, as we often call it in that context, and what the form is of those indicators. For example, if I'm going to write a questionnaire, not only do I need to know what I'm asking, but also how I phrase the questions, because the language we know is crucial to how people understand it and interpret it, and it may not be what I expected. We can also use quantitative measures as a prior basis for then developing qualitative understanding afterwards. So, for example, we may do a survey, a quantitative survey, and then say, here are the issues, this is where there's some clear concerns quantitatively, let's now do some qualitative work in those areas. Let's focus in the subsequent method. But we can also see this as an alternating process, and quite often the work I do, this is what I'm doing, is working between the different methods one after the other, exploring, confirming, rechecking, going back to basics, and so on. But we could also think of it as parallel methods. In other words, we may want to do some work, let's take an example, wards, at ward level, doing quantitative surveys at ward level, but then at the hospital level doing something more qualitative, trying to understand, say, the professional culture or the organisational culture in more qualitative ways. So the surveys at ward level are nested within the hospital level in that case. What I'm going to do now is just to give you a quick example of some work we were doing around the English patient choice policy. And I'm just going to give you a very brief sketch. Some of you may know a lot more about this than I do. But choice, I think it's very clear, became, I call it the mantra of all new Labour government health policies in England since 2000. And it was based very much on an assertion, not always on unequivocal evidence, I should say, of its drivers and causal effects. There was a belief or an ideological position that competition in markets would improve healthcare. And it was believed that this would lead to improved health system performance, increased patient responsiveness, and increased equity. Now, those are big claims to make, and for those of you who are more UK-based, you will probably know a lot of the ferocious debates which have occurred around some of those assertions. Anyway, I'm not here to debate the politics, although I'd be very interested to do so. And it's very clear that with the new coalition government in the UK, there is no obvious change. But the question I was interested in asking with colleagues is, what do patients think about this policy in practice? So the research question, so I'm going to put it in research terms, but I hope you can see the relevance of this, is what do people see as choices in various types of healthcare? So the objectives were to understand how users and carers perceive and value choices for different conditions or situations. And we also wanted to know how socially differentiated these people were. In other words, were the differences based on age, gender, social class, ethnicity, and so on, regarding this understanding of choice? Well, very briefly, what do we know already before we started this? We know that the desire for choice and involvement in decision-making varies. It's not something that everyone wants to do, or at the same level. We know that there is increased burden of pressure to choose, but also with it, there is increased responsibility. Whenever you're more involved in things, you take on more responsibility. For those people who perceive themselves, rightly or wrongly, to be in life and death situations, this can be seen to be a really heavy burden, with a potential for what's called post-decisional regret. In other words, having made the decision, you may then say, I wish I hadn't made that decision, but it's too late. The decision is made. Another thing we know is that the potential for choice is not always recognised, and even when it is perceived or recognised, it isn't always wanted. We know also that patients' involvement in decision-making can take a variety of forms. So it might be, just tell me the things I need to know, or it might be, please listen to my stories about it too, or it might be, I want to make the decisions with you, or even, I want to make the decisions without you. We know people adopt different positions at different points in different contexts. Even if they feel involved, it doesn't mean to say that they've necessarily... they can feel involved even if they haven't had an influence on the decisions that are made. And ultimately, choice may not be what matters in relation to involvement in decision-making. So a number of issues which we were aware of. We took 3 different conditions to look at this, quite different, deliberately different. First of all, antenatal screening of women, whether or not to have a screening test for Down syndrome in the recent or current pregnancy. Caring for people with dementia, where the person with dementia lives and is cared for, either with you as the carer, in their own home, or in a care home. And finally, people who are diagnosed with lymphoma, whether or not to have treatment, both Hodgkin's and non-Hodgkin's. So what we were doing methodologically was combining multiple case studies of these 5 conditions. I'll become clearer why we're only looking at 3, and a survey of 3 of them. And so what we set off to do was to analyse secondary data. This is something which you may have heard of, Health Talk Online, which is a web-based source of data. Sue Ziebland was working with us, who's the director of that project. It was known as DIPEX at one point. And there are a lot of interviews with patients, carers, or actors acting on behalf of those people, talking about experiences. And we looked at and analysed 184, and it was a very, very large set of analysis. Looking at antenatal screening, ending a pregnancy for fetal abnormality, sickle cell and thalassemia screening, lymphoma, and carers of people with dementia. The first 3 were combined because we found the issues to do with decision-making and choice were not very different. And so for the second stage then, well actually we had focus groups, but not to do with this question. The second stage of this set of questions was an interview survey, a very quantitative, structured interview survey based on those initial analyses of those 3 conditions I mentioned. How did we analyse it? Well, we used a framework approach and a thematic analysis of the qualitative data to understand the concepts, issues and processes, and we also had a fairly heavy statistical analysis exploring, describing and trying to explain results of the surveys. So in other words, we were doing a classic mixed method study. You probably will shudder when I start talking about philosophy, but I just feel because it's really fundamental, and people will disagree about this, I'm quite sure, it's quite fundamental to whether or not you can combine methods. And it does orientate itself around these questions about what exists, or what we call ontology, and how we can know it, or epistemology. In other words, in this particular study, we were trying to combine a constructivist approach, which means we were enabling, we hope, enabling patients and carers to say how they understood their position in that context of those decisions. They were constructing their story, if you like. And we were also trying to do something more objectivist, in the sense of saying whether or not they know it, there are things that exist, independent of their knowing, possibly. So for those of you who were in the session before lunch with Ma and Baxter, they were using a very objectivist approach to understanding, saying it's not about opinions, beliefs, feelings, it's about what actually happened. In other words, an objectivist view. But we took the view that this could be constructivist as well. How can we know it? Well, what we were doing was using people's interpretations and our interpretations as researchers of how people constructed their stories, and using what in the trade, if you like, is called critical realism. In other words, we were saying there may be things which we can't actually see, observe, but we believe they exist. But we're attending to those things in a more critical way than simply saying they exist as givens. I probably haven't explained that very well, but I can come back to you if you want to ask questions about it. So what we were doing was also the process of what we're trying to do was moving from what I call an inductive logic, in other words, let the data speak to us, and then trying to deduce from it a number of hypotheses which were generated. So it's going from out of the data back to trying to confirm certain understandings. So what we were doing then was giving primary focus to the understandings given by social actors, if you like, but at the end of the day, what we were trying to do was to make generalizations about these different conditions, decision-making in different conditions. And as these two well-known sociologists say, the ways in which practical, ethical, and political issues arise in all research demands pragmatism. Now, I have taken the pragmatist approach. Some people say, no, you must have a purist approach. You can't mix different philosophical positions, and I think we will argue for a long time about it. So what's the purposes of mixed methods in this study? I gave you 5 different purposes. We only really looked at 3 of them. The development, the complementarity, and the expansion. We weren't concerned about trying to triangulate. We weren't trying to say, do the surveys show that what they said was correct or not? We don't think we have a basis for doing that. So in the development phase, we were trying to combine the strengths of more than one method in relation to these fundamental concepts and issues, and how we ask about it and how we measure it, to try and increase the content and construct validity. The secondary purpose then, in terms of why we were using mixed methods, was trying to use the basis of the qualitative analysis then to elaborate and increase the meaningfulness of those results through doing a more extensive quantitative survey, and ultimately to try and strengthen and reduce relative weaknesses, so strengthen the methods and reduce their relative weaknesses. But we were also trying to build up, follow on from the initial analyses, qualitative analyses, to build on that and try and understand more in the survey. This is probably a bit detailed, but I'll just try and run through some of the main things we were showing here. So this is combining the case study with the survey data in the same decision. So we can see here from the case study of screening for Down syndrome that we separated routine scans, as they're often known, ultrasound or dating scans, from diagnostic or abnormality scans. For the routine ones, those who saw choice had greater personal experience rather than formal information sources giving them that knowledge. And they also had more understanding. Others saw it as quite routine, expected, especially in earlier pregnancies, less experience. I won't worry about the diagnostic tests because they're a bit different. For the survey, we were focused on the routine. And most felt they had a choice and influence. There was more awareness and information seeking among highly educated. In fact, that was a sense of triangulation. That seems to be proving, if you like, what we found in the case study. And we found that the key influences were the partner, the GP, a little bit of the midwife, and a third saying no one influenced them. And it was interesting that the midwives were more likely to be seen as influential by graduates as opposed to non-graduates, 3 times as likely. But that discussion with midwives is more likely than people who are more deprived. Now, I'm not saying deprivation and graduation are necessarily the opposites of each other, but there is a correlation there. But we can see that just because you discuss something with somebody, it doesn't mean to say it's perceived to be influencing your decision. We could argue about why that is. And in fact, there's a lot of interesting issues around why certain people talk to certain other types of people and not others. In terms of people with dementia where they live, the case study showed that most carers were usually aware of their choices, but a sudden change, for example, the person they were looking after was sectioned or the carer was ill, felt like a loss of control and an absence of choice. In other words, it wasn't seen as a choice if you're unable to care. It was often seen as routinized rather than considered to be a decision or a choice. When you have a partner, husband, wife, that was seen to be the reciprocal arrangement, not a choice. It's something you did because you were a partner. It also felt to be quite an unwelcome burden to have this power over others about where they should live and be cared for. The survey showed similar things, but gave us more detail. So it showed that just over half were aware of choice, more so by women, and especially if not caring for a partner. Most felt they had an influence. Key influences are listed there, the relatives, GPs, social workers, although a third again said no one. And the younger were more likely to find other relatives and GPs influential, partly because they were less likely to have a partner. And finally, for treatment or not for lymphoma, the case study showed that decisions are heavily protocol-driven. And so the only apparent alternative to people is to refuse to have treatment, which is not felt like a choice. When the treatments were seen to be new, experimental, possibly high risk, then that was usually seen as a choice, and presumably presented by professionals as being a choice. So one decision might be seen as a choice, while others not. So it very much seems to depend on how the decision is presented and made. Not all wanted choice. Many preferred to trust the professional, even if they felt they had a choice. You could see this as being one of those potentially very life and death type situations. The potential for regret was very high. In the survey, more detail is presented, so we can show that just under half felt they had a choice, more educated finding more so, and a little more, just over half, felt they had an influence. Key influences being hospital doctors primarily, but also partners, a little bit the GPs and their children, 17% saying no one. Discussion was mainly with hospital doctors, as you may expect, and partners, more so by men with their partners than women agreed with their partners, interesting, and children. So what do we learn from that, using these different methods? I think what we can see very clearly, and there's a lot more detail we could go into, is that the perceptions and values varied a lot by the condition and the type of decision. It's interesting that sociodemography provided less explanation than that context in which the decision is being made and what the decision is. When we do focus on sociodemography, it seems in this case that education, which is age-related, is providing more, but still quite limited explanation than gender or deprivation. I'm just going to hand over now to Piera to talk about an Italian study.
Thank you. And then we come back to the conclusion. I would like to share with you two projects that I have run, and of course was through a mixed method, but I also wanted to explore how the perception by citizen, patient, and users and professional were about the concept. So the first reason to use different methodology, and first of all the qualitative methodologies, was related to the different perception, the role of the context, because of course there was a lot of literature related to surveys and analysis, but we had not enough research on this concept in the Italian context, and we did not have any research on citizens related to the cancer screening. This project was related to the cancer screening. So we tried to understand what the concept were, the priority were, why if the, for example, the service user were influenced by the relationship with the professional, and what was the understanding by the professional of the user and the citizen. So because of the time, I did not. I chose not to present all the analysis run through the interviews and the focus group prior to the 3 surveys, and then using also triangulation. I just share with you that was very interesting and helpful also for the action taken after this project related to the differences or reciprocal understanding by citizen, professional, and users. Another important issue I want to share with you that was to try to also develop an approach and a methodology to be used by the services, not just during this project, but always in order to better understand the context and the people. So just a few findings. Just you to see, users say only 60% of users say that the letter used to invite them to attend the screening was very helpful and was the decision driver. The citizen, only for the 31%, gave the same answer, and the professional related to the 81%. So this could be just one of the key that people can use to discuss after in order to improve the relationship and make a better campaign or information to people to attend the service. Leaflet and other written information, also in this case, we had a different perception by the 3 subjects. The compliance also to the services, we have the user with a different approach related to the citizen one, and also the role of communication, was the role was helpful and was effective to strengthen the understanding of the role of the screening for people and the importance to come back. And also the trust, do people trust professional? Do people really find this helpful for them to come to the service where they helped by the professional? We have a close perception by users and professional. This was just to give you, of course we came through these surveys after all this work with the qualitative studies. And another work that I wanted to share with you, always with related to the context and also related to the different perception. To me, it's impossible to work or to understand only patients. I also need to understand or to better, deeper the knowledge related to the citizen and also the professional. Because if the professional feel well and have a good relationship, all the partners can really create a partnership. Otherwise, we look at each other, but don't we really create a trust? In this case, the same. This was a replica, but with many differences of the Eurobarometer study. And we had interviews, focus group, again, with citizen, user, professional, and then 3 surveys. And just to share you with a couple of findings, because of the time related to the surveys, the question was, do professionals have to involve more citizens? And yes, we have a very close answer. We have almost 90% of citizens are requiring to be more involved. But also, no compliance of the care can contribute to errors. This because, of course, if we talk about patient safety and we need to involve citizens and patients, we have to also have them to better understand or tell us what can really make us make errors due to different behaviors or not understanding of the care. So we had a very huge number of citizens thinking that they can contribute to errors if they do not comply or do not agree with the care. Sorry, also sometimes it's difficult to find the right way to translate concept. And also patients not telling their habits contribute to errors. We had many adverse events due to this and unfortunately not well discussion or good understanding between professional and patients at the service admission. So we try to understand this, and we also have a close relationship between citizens and professionals. And then patients to be always told errors. This is another interesting question, and I just reported to citizens and professionals that both agreed on this, and we also have patients almost with the same. But my concern was to really better understand the concept related to the context, because I think that this is very important for us, and then to understand and see through qualitative and quantitative methods. Please go to the conclusion.
Okay. Conclusions then. I'm not going to draw out too many, but I think methodologically, which is the main focus here, I hope it's shown you, and it's a very cursory look, I know, that there are potential strengths and complementarity in these different methods. But sometimes we do get conflicting findings, and it's not always easy to understand why. But as a researcher, that's what I find very interesting, why different methods do produce what appear to be conflicting findings, because there are opportunities to learn a lot from that. I think also, perhaps I should say, and I didn't describe it very well, I don't think, the philosophical positions, but this could also be a major problem about trying to bring together whether you believe that patients construct what is real themselves or whether there's reality beyond them that they're not aware of. And that's a fundamental problem. Substantively then, in terms of this particular project, what we can see then that choice was more likely to be recognised when you're more educated and with more experience, and less when it was seen as routine or protocol driven. It was more emphasised when the outcome is recognised to be uncertain. But when there are social or moral obligations, for example, with, caring for dementia patients or people with dementia, that's not usually considered to be a choice. Options when there's a possibility of post-decisional regret and self-blame is potentially, where that's potentially severe, it's less likely to be seen as a choice. The more risky the outcome, the less choice is wanted, and the greater the desire and willingness to trust professionals. And it leads me to conclude then that choice, taking all those things into account, implies it's only operable when there are acceptable alternatives. In other words, when different outcomes are equally acceptable, not unacceptable. So my final slide is just the acknowledgements for that project.
We can say about the cost. Yes. I would like to share with you that often people ask during the work we have done, oh, this is costly. Why do you need to use all this method? Why do you spend so much time to go through all this? But to us was important really not to just make a survey. It was important to do something useful for people and to really understand the concept. So this is why we decided to combine qualitative and quantitative method. And of course, just you to know, we developed at the end, in our case, also instrument online, because, for example, for professional, one of the important issues was privacy, not to have a questionnaire or opportunity to be seen what they thought in their services. So we try to develop also online. And also for citizens, we use interview and focus group, and then we use the questionnaire distributed by researchers. But at the end, we also provided for the future, this is an outcome of the research, online questionnaire in addition to other questionnaire in order to have people be free to give advice. So, thank you.
Thank you very much indeed, Andrew and Piera. Let me join in welcome and thanking you for them. That was a... No questions at the end, Piera, if that's all right. That was a very intense look at the methods used for getting the best, most understanding of what patients really think. Now, two presenters from Amsterdam are going to talk about how they elicit and engage patients in their care at their hospital. So let me hand over with no more ado. You introduce yourself.
Thank you, Jane. What we found very important is that you learn from our experience, but also that you learn from each other's experiences. As the time is too short and the group and the audience is too big to have some interaction with each other, I would suggest you just shake hands with the people you don't know next to you, in front of you, or sitting behind you, so you have somebody to talk or share experience maybe in the break here after. And that gives us the time to start the presentation. Ja, maar ik weet niet welke je moet lezen. Ja.
I'm sorry to interrupt now. Good afternoon. I'm Rolande Franks and this is Christine van Hartingsveld. We are both healthcare advisors in VU University Medical Center here in Amsterdam, very near from the Rye. And in our presentation, Improving Quality of Care by Patient Engagement, we really like to share our experience with different methods of patient engagement in the hospital setting. The goals of our presentation are first to share our experiences in implementing different methods of patient engagement and also to give you the possibility to identify the usefulness of a method for your own organization. First, we want to have a few slides about organizational context of VU Medical Center. And then we give you a brief introduction to patient engagement, and we expose 4 methods we use to end with some conclusions and the challenge we're facing. Because VU Medical Center is an academic hospital, we have 3 core tasks: education, research, and patient care. For this session now, I will only concentrate on patient care. To give you an idea of the volume of the hospital, this is an overview picture of the buildings. You see here in and outpatient department, which are connected by a bridge, and a road is driving under the hospital, as you can say so. The university part is not really on the picture. And we are still expanding because of mergence with the mental health institution, GGZ in Geest, for example, which is good, of course. We find good. Some figures here. As you see, we have quite a huge amount of patient contacts. For example, the outpatient department this is on 1 year in 2009, actually, is more than 300,000 a year. The organization is vertically structured with self-directing divisions with their own boards. And to create patient-centered care, we made 60 care pathways we developed, which cross through the system. And on the care pathways, all the patients move along. Patient-centered care is it's a good thing to have, and of course you really need to involve the patient's perspective. in order to realize patient-centered care. So I'll just show you our mission, which fits in that purpose. VUMC combines belief in personal approach and in treating people with decency and respect, with a healthy degree of ambition and fundamental curiosity. Our definition of patient engagement is to make use of the unique experience of patients in order to improve the quality of care. We like this definition because it stresses the value the experience of patients have for our organization. We really think that experiences of patients are very useful for us to improve quality of care. And of course, the goal with that is to meet the needs and expectations of patients as much as possible. So now we get to the different levels of patient engagement. Here you see the participation ladder. Maybe some are already familiar with this. It shows the different amount of influence patients have in participation, in engagement. The ladder, I won't theorize too much on the ladder, of course. It derives from Leni Jansen in 2001, but I'll use it only to place the methods we use on the right level on the ladder. So to start with information, it's certainly not, it's the lowest level, but certainly not the most insignificant one, since patients need to be informed about every aspect of care they have to deal with. But we call it here low level because patients are rather passive, and they have little influence on this level. So there are two instruments we use in the hospital. That's mystery guest and shadowing. And mystery guest will be explained later on. The second level is the one of consultation. Here, professionals seek actively patients' opinions. In VUMC, we use 4 different instruments for this level. And within these instruments, the range of the activity patients have is different. For example, in the NFU patient survey, they only ask questions. That's also the case for the web application, patiëntenervaring.nl, which later on you hear more about that, and instant feedback, whereas with storytelling, a patient is really actively setting his or her own topic. On the level of advice, patients are in direct contact with the professionals. They are explicitly asked after their opinions, and professionals are really willing to listen to their ideas and also to act accordingly. And they must really have good reasons not to do so. As you can see, we have 6 instruments on this level we use. Apart from the mirror interviews, which will be exposed here during the session, we also have the client council for university hospitals, which are for all the 8 university hospitals in the Netherlands. We have an own patient participation board in the hospital, which consists of 7 patients or relatives. We work with focus groups, patient journey and suggestion box. On the level of partnership, patients' role in the decision-making process is equal to the professional's role. This is the case, for example, when patients are part of a project team. In VUMC, we have adopted patients in 2 quality committees of healthcare workers, which are the Committee of Patient Safety and the Committee of Patient-Centered Care. So the highest level is the one of patient direction. Here the patients themselves set the goals and the priorities, and professionals only give advice. An example of this is self-management in care, where patients learn themselves to take care of themselves and You see this with patients with chronic diseases. We have in VUMC a self-management program for diabetes care. Another example is e-health, which is now coming up, very quick. And that's an interactive tool for information and communication for patients and healthcare professionals. E-health in VUMC is implemented for gynecology patients and is now being developed for multiple sclerosis and Alzheimer. Also, trainings for professionals in e-health have been given. On the dimension of the organization, you can think of placing patients in the board, but I don't think many organizations until so far have chosen for this. So adding up all the number of all the methods, you see that we do the most on the level of consultation and advice. Now we will expose some methods a bit more. The mirror interview, patient survey, the mystery guest, and storytelling. If we start with the mirror interview. It's a group discussion with 8 to 12 patients and their relatives and an independent discussion leader. The focus of the interview are the experiences of the participants with the care and service they've got in our hospital. And the interview is attended by all the staff members of the unit involved. These are mostly about 20 to 40 people. We call them audience. The audience is not participating in a discussion. They only can ask questions afterwards. A mirror interview is a qualitative instrument which is used to get more in-depth information in addition to quantitative measurements. It can be used in every phase of a project and is very effective for the consciousness raising of healthcare staff because they are confronted directly with the personal stories of patients, and this facilitates them to put themselves in a patient's shoes. The arrangement, the mirror interview, you see here 2 discussion leaders on top, which is mostly the case, and patients are sitting in half a circle or horseshoe, facing the discussion leaders and with their back to the public. This creates an intimate atmosphere in which patients really feel free to disclose their personal stories. In VUMC, we trained also our own discussion leaders, so now we have a pool of about 10 people who can be deployed wherever needed. A few examples of results we find with a mirror interview are the following. Always mentioned by patient is a need for more or better information. So as a result, some units in the hospital, they introduced a patient diary. Diary contains all the important information patients should know, and it's also an interactive tool for the doctor and the nurses. So the patients can write the questions they have down in a diary so they won't forget when the doctor will be around. And they can write down the answers of the doctor again. So this is very helpful for patients. Another topic is the discharge care. This has resulted in a better exit interviews with patients and also in calling patients up when they're home after their hospital stay. And this is very much appreciated. In terms of privacy, for example, a leukemia patient reported that they really needed to be alone with their relatives in a private room on the moment the stem cell donation actually took place. But beforehand, the staff wasn't really aware of this special moment. So this could easily be arranged by the unit afterwards. Another privacy gap sometimes had been that bad news had been given in a room when other patients were around, which was also, of course, not very much appreciated. And what was frequently mentioned, not only with this method, but in general, that patients really do need somebody to coordinate all the care they have or they get in the hospital, because they easily get lost between all the appointments and different units, departments they have to move to. So now on many units there is a nurse practitioner who has this role, coordinating role. What are the strengths and weaknesses? First, we see that patients appreciate very much that professionals are interested in the personal story and take the time to listen to it. And second, the mirror interview is a very strong method for raising consciousness among professionals about what patients are going through. This is far more the case than, for example, with a patient survey. This is also the reason that many professionals evaluate this method as positive. In every mirror interview, blind spots are uncovered, which is good, and a mirror interview generates concrete ideas for improvement. Some weaknesses are that it's rather time-consuming, the preparation, and also the session itself, which lasts for 2 hours, asks the availability of all the healthcare staff of the unit, which has to be arranged. And about the results, of course, because it's a qualitative method with few patients, you cannot generalize it to the whole population. Sometimes a follow-up on the interview is lacking, which is a shame, so that not all the inputs they get are really used for quality improvement. It's the responsibility of the unit not to let this happen.
I would like to explain 2 other methods to you. The first one is the mystery guest. And there what you see is that a fake patient follows the same route as a normal patient. But he investigates the service delivery and the personal attention he gets through the care pathway he follows. So the mainly focus is on insight in care and service delivery of employees. It can be administrative or, of course, medical employees. This method is really from patient's perspective, as the fake patient follows the same route as a normal patient. Results initiates improvements, for example, in the attitude of employees or given information or the care delivery itself. I just want to show you an impression of results that you can get from this type of methods. This was the nursing department of surgical oncology. They wanted to investigate how the patient's welcome is, if the treatment has been quick and efficient, how the medical personnel is, are they competent, are they civilian, and if promises are met and expectations are met. Here you see just an impression of the improvements or the results that was coming out of this mystery guest visiting the nursing department. The patient really felt welcome and the personnel was very helpful, experienced hostmanship, and an open culture felt very welcome. And the information given was also good. The mystery guest, gave us feedback that he would recommend this nursing department to other patients. However, there are also, of course, room for improvements. For example, the salutation could be better, saying hello, offering something to drink, and you see that there could be more explained about the questions that are posed, why they are posed, and why some research is done. Another mystery guest visited the department pediatrics. Here you see that improvements can also be very small. Making eye contact at the registration desk. It was a bit messy, make things organized. The waiting room, for example, there could be more reading, and especially for this department, of course, it's important that there are a lot of toys. And employees just wearing a name badge so the patient knows who he's talking to. And, of course, information is always very important for a patient. What we like of this method and what we see in practice is that the results really are given from the patient perspective. It gives a lot of insight in service delivery and possibilities for improvements. However, we also see that employees can have the feeling they are spied. Of course, sometimes we announce that the mystery guest is coming, but sometimes we are not. We want that the employees just deliver the cares as they always do. It can cost a lot of time in the preparation and execution. And sometimes, if the fake patient, the mystery guest, does not have a real healthcare need, the care is delivered for nothing. Of course, we don't operate those patients in the operation theater. We like a lot of paper in VU Medical Center. Of course, luckily not for the patient survey. We have a website for that. The patient logs on with a code on the right above. It should working, yeah. And he answered the questions the healthcare unit or the healthcare outpatient department want to know. Each department formulates its own question. It can be about privacy, it can be about the given information, about the treatment. Most of the time we ask them to just ask 5 or 8 questions to the patient, not too much, so the patient really wants to answer those questions. Most of the time the patient answers those questions online on this tool. But elderly patients, for example, don't have internet or they have troubles starting with the computer. So we give the possibility to answer those questions on paper. And, for example, nurses enter those answers later on in the tool. And then you can see the results online. There is also a patient from the Patient Participation Board playing a role in this. He helps the departments with formulating questions. We already heard earlier that it's very important that questions are understood and that you get the results of it you want. This is, for example, the nursing department, that's the next slide. These are the number of departments using this online tool. We have 46 departments and 34 departments are using this online tool, and 8 departments are developing patiëntervaring.nl, this online patient survey tool. 4 departments don't use this tool, however they use other methods to know what the patient wants, where improvements are possible in the patient care. The other refers to a patient care pathway where they want to know how the care is delivered and perceived for just one treatment. These are some results from the department cardiology. Well, this is a graphic you can get from the online system. They wanted, for example, to know if the department, the outpatient department, was good accessible. Well, luckily here you see that most of the patients could reach this department by phone. Only in the month of January there's 1% of patients having trouble. They also want to know if the patient had enough privacy in the waiting room and at the reception desk. Luckily here also most of the patients felt free and safe and had enough privacy. We come also to some negative results, don't worry. Here they also wanted to know if a patient is interested in visiting the department during the evening hours on Wednesday. Some outpatient departments have just patient contact in the evening, and they wanted to know if they should extend their hours. Well, here you see that less than 50% of the patients is interested in visiting this department. So this can help the doctors in the decision making about extending their hours or not. This is the Department of Vascular Surgery. They wanted to know more about their discharge procedure, how patients experienced, if they have if there is room for improvement. What you see here is that not all patients did have a discharge appointment. Only 70 to 80%. So here is room for improvement. Another question they asked is if the patient know when he or she is at home, in which case of complaints he should contact the GP, the general practitioner. Well, a little majority knows when he should contact the general practitioner. So here, should be more focus on the information to the patient in the discharge. The same with what the patient should do or not do at home after the operation. Not all patients do sufficient know what they can do only 50 to 60%. So also here, the discharge procedure could be better. You see that they made a discharge folder in this department. They also planned better all the discharge appointments, making sure that the patients did not leave the hospital before having an appointment. Unluckily, it's 100% is always very difficult, but they really focused on it. And here you also see some other departments giving improvements also on discharge, but also being more strict, for example, on visiting hours. They are there, not bothering patients outside these hours. There were patients or relatives coming outside these hours, bothering other patients that needed their rest. So more focus on that. And for example, a very small one, just illumination equipment on the delivery rooms, so women can read when they want and when they want to relax in a turbulent time. The rehabilitation department, for example, used the patient diary, already explained earlier, and also what you saw with the mirror interviews, one point of contact for the patient is very important. The nursing department, surgical oncology, for example, made a photo of the responsible nurse in that shift for the patient and put it on the patient room. So the patient always know who can I contact in, well, these hours, as a lot of nurses are passing by during the days for a patient. And also here, more focus on discharge. What we really like about this method is that it is direct focused on the department itself. It's very easy accessible for the department to ask some questions about the topic they are bothered with and they want to ask to the patients. And we see that it really helps in creating an ongoing learning and improver culture. And well, we see that asking a few questions, and especially open questions, helps a lot in getting insight from the patient's perspective. And happily, of course, there's always room for improvement. We also see that with this method, that most of the time 1 or 2 nurses are involved with the questionnaire and with getting the results and giving the feedback to the team. And that needs, then you need a lot of enthusiasm. So that, we really have to focus on that those persons and all teams really, rest enthusiasm all the time. That's not done one time and then going down in use. Rolanda will go on with the storytelling, another method.
Yes, it's the last one, storytelling. It says itself, the patient or relative shares his or her experiences with the care professionals by telling a personal story. And this is recorded on DVD. And DVD is used for training of healthcare professionals. What we see in FUMC is that this method has great impact on healthcare workers who are watching, that they are very much affected by hearing the story. We made a movie for Annemie, in which a husband shares his experiences around the loss of his wife during a medical incident. It's a very personal and very moving story that made great impression on those who watched the movie. The man did this because he wanted to learn healthcare professionals from his experiences. For those who are interested, we have a web-based application of the DVD in English version. For requests, you can send us an email. So we come to some global conclusions of our presentation. As the former speaker already made it very clear that we also find multiple methods can be used together, and quantitative, qualitative instruments can be very well complementary. Each method has, though, its own strengths and weaknesses, and it depends on the situation which method you want to use. And not one method is better than the other one in case of results, in terms of results, because they all can lead to the same results and improvements. And improvements we made are concerning the topics of information delivery, attitude, service, facilities, and the coordination of care. The challenge we face now is to get from the use of single methods by individual units to structural implementation in the whole organization. That also means to embed the use of patient engagement methods in the quality system and in the planning and control cycle. Of course, we are very interested how other healthcare institutions manage in doing this. Thank you very much for your attention.
Thank you. Thank you very much indeed, Roland and Christine. It's now open to questions from the floor. So might I invite Andrew and Piera to come up, and it's now your time to respond to this. I think we've got some roving mics and some people to wander around with them, have we? Excellent, we have. Right, now, can I see some hands up? Over there. Have you seen it, lady with the mic? Yes, excellent.
That's great. My name is Taher Mahmoud. I'm a clinician, pathologist in fact, and we've been interested in patient feedback for many years and have been using that in a systematic way where we ask every patient that we see in clinic for their feedback and use that to reflect at the end of the clinic or the ward round to see what improvements we can make. And as a result of that, we've made a number of changes in the service. And I would really I'm very impressed with all the work that's been presented, and I would make the case that each clinical interaction should be rated by the patient and their feedback used to improve the service. And that should be the focus of what we do, and have the more systematic, wider feedback as another element, but the clinical interaction is the most important. If anyone's interested in that, then there's information and the questionnaires on patientinvolvement.org.
Thank you. Do you want to respond to that, or?
Thank you.
Okay, no, thank you for that intervention. That's helpful. How practical is it to do it for every intervention?
Actually, it's very straightforward. They really expect to give you feedback. I mean, patients, as you know, are the most resourceful thing that we work with. They're incredibly knowledgeable. They're very aware, and we provide a small fraction of assistance or direction or guidance. They are really the owners of their condition and show a great leadership. We need to, as healthcare professionals, make space for them to be able to express themselves. And in our experience, about 90% of them will feedback and be really, constructive but forthright, sharing their experience and expecting change and improvement over time. Sorry, just one small point, if I may, then. What we've been able to show that about 86% of our patients take their treatment. As you know, the published average is about 50%, and more of our patients are in remission. So you can translate that to some objectives, such as how many are people taking the treatment, and also their outcomes. More of our patients are in remission. So I think these feedback mechanisms can have real impact on patient outcomes.
Thank you very much. Yes, Andrew, please.
I'm generally in favour of...
Closer. You have to be closer to the microphone. Yeah.
All right, it seems to have gone up.
There was one on the floor.
Microphone's not...
Hello? Oh yeah, I had to press a button. I think the message is well taken, but I think at the same time I just want to draw in a note of caution. Not every patient, not every carer, not every citizen is able to articulate these things very well. And I think we have to think of ways in which we can enable them to the level they can do that, but also recognise that professionals and others involved in healthcare also have a contribution to make. It's a bit like when my students say various things to me, and I say, well, that's something I need to know, and that's really good, but I think I also need to engage with you in how I see it as well. And it's more about a dialogue that's appropriate to the person you're communicating with, I think.
Yeah, nice point. Thank you. Right, more comments, more questions. Yes, down here. Thank you. And then the lady in front next.
I'm Jesper from Denmark. Thank you for sharing possibilities of engagement.
Thank you.
I'm curious about how to choose between this kind of methods. Also because there's this problem about how to engage all patients. So can you say a little more about in what way you decide how to use methods in a given clinic?
Who wants to take that?
Thank you for your question. We don't have a method for choosing, but you can say like for a process, like if you want a logistic process being evaluated by patients, then you can use shadowing or mystery guest, for example, because they're really going step by step, following a patient through the hospital. So that's quite obvious for us to do that. And but a mirror interview, for example, you can use almost everywhere. Because you also can ask patients in the interview, tell me about from the first start to the end. What did you see and what happened? So but maybe from a methodologist point of view, you can add something to this question. But we don't really have very strict criteria.
Thank you. Do you want to respond, Piera?
If I can add, in my experience, of course, from a scientific point of view, every method has pros and cons and is used for something. But in my opinion, it's very important also to involve the personnel, the staff. Because if you do a mirroring, for example, I am now working with the Ministry of Health and we prepare a handbook for professionals. But if professionals are not able to deal, for example, with mirroring or the result of them, I suggest not to use. So I think it's a common pathways. In every institution, you have to involve the staff, work with them, and have always see the phenomenon from the different point of view, choose together the method, because what we have to do is to work together between citizen, patients, and professional. If you do a nice research or nice project, use for example, a story narrative or a mirroring or whatever, and people and your staff don't feel well with the result of this into the hospital or in home care, I think you are going to get moral distress, conflict, so I am really scared. So in my opinion, it's a common growing. We have to do together, grow together, and develop methods, learn about new methods, the potential of the methods, but we have to do this together. And also with the CEO, excuse me, I just said something. In our work, we also made Delphi with the CEO when we developed the research and the project. And it was very interesting because often the director of the hospital, the CEO, are very far. They do not see the problem. So we use safety workaround now, for example. But it's very important to involve all. Otherwise, you are not able to have success, in my opinion. So the key is just choose the method together, learn together, and choose method ready for the context.
No, I think this is one of the difficult questions, is which methods, when, and how. I think there are obviously different methods for different purposes. Although we're trying to look at the same issue, we may have very different approaches for various reasons. So obviously there's a distinction between qualitative methods and quantitative methods, largely in the basis of the qualitative methods are trying to give you understanding of the concepts, the underlying issues, the meanings in things, whereas quantitative is clearly about measurement, where, what's the scope of the problem, where are the particular issues, if you're trying to generalize, much more about external validity and so on. Not all quantitative measurement is about that, but a lot of it is. So those are kind of fundamental differences, but then also you have to think about, for example, we often focus on individuals, but it's not just about individuals. People come from families, they come from wider social groups and so on. So you may adopt a group approach, like a focus group. A focus group has great value. It enables people to interact between each other without having somebody telling them how to respond or what they've got to respond to, and you can look at the dynamics of that. But then there may be issues which individuals don't want to divulge in a public group. They may talk about the things which are publicly acceptable, but privately discreet. And so then you might say, I need to complement that with the individual interview, or it might be something even more divorced from face-to-face, which can be quite threatening. So it might be patient diaries. I've certainly done a study of maternity services where we've asked women who are pregnant to write diaries, but then at the end said, look, if you don't want to hand these over, you don't have to, because it may be they're writing down things which they would rather not divulge, having written them down. And clearly a combination of these different methods will bring different benefits but also different problems, and I think it's trying to being clear about what your objectives are. So when you're mixing methods, as we started, then I think you have to know, are we trying to triangulate, trying to corroborate, or are we trying to use one to develop another, or are we trying to understand more about the first from the second method, or it may be a combination of these things. So I think clear strategies for what you're trying to do would really help to guide you.
Thank you. Do you want to follow up? Quick one.
I was wondering about involving patients in deciding how to involve patients. So you can be sure that all voices are heard, because one of the problems are not all using the surveys, for instance, not all are willing to do interviews. So how are our patients willing to give us feedback?
Who wants to respond to involving patients in how you involve patients? Any experience?
Yeah, I did a big study which is in social science and medicine on this, trying to think, 2007. On patient involvement and participation, it's called, and trying to understand how patients themselves understand involvement. And it's very much based on the Einstein ladder you saw, which I've forgotten who the writer was, which you referred to, but it's based on the 1969 article, American Planner, by Sherry Einstein, using this ladder of participation. But it's basically trying to develop that and understand what do these levels mean and where do people fit in, but not saying that an individual always wants to be a decision maker or always wants to be just receiving information, but which context do they want to be in, one role or another. And you find that contexts change, they change their position for what become obvious reasons when you find out what they're saying about it. So, I'm just giving you my example, but there's quite a few articles I could refer you to if you're interested to know about that.
Thank you. I think the lady down there, and then there was a lady over here, I think, who had a hand up. Yes, excellent. So,
hi, Mia Carroll from New Zealand. Thank you. I think you've almost partially asked the question that I was going to head for, but I would ask the group if you would comment on the degree of cultural acceptability of the processes that you're using. Clearly, I come from a country where to engage in patient engagement requires cultural partners to participate. And the other thing that sort of governs a lot of my world is the literacy of the people that we're trying to engage with, and in a way that makes it meaningful for them. So I'd really welcome any comments or tips or strategies, and maybe it's those articles I need to head to, but happy to hear.
Who wants to start with that one? Roland?
Okay. I start with the last one, the literacy. Until so far, we used patients for the engagement, which we didn't have a problem with literacy. So it's a good question you pose, how you reach patients who do. On the other hand, I think that we in our hospital, the amount of illiteracy might not be very big, but we also have non-Dutch speaking patients, of course. So that's also something to think about. We haven't yet dealt with that. I have to say, but that is something to for the future. And the cultural aspect, I'm not sure that I understand what you mean by that. I don't know if somebody else does. You do this?
Just adding a short point for the literacy. For example, what we do with elderly patients, but I think you can use it also for those patients, is that we have volunteers just asking the questions orally and not marking down the results of what the patient answers. So that could be something you can use, for example.
Piera, do you want to respond on the point about cultural
Very quickly.
differences?
I work now on this, and my question is, first of all, I try to learn also from other disciplines, and in my opinion, all the patients want the citizen and the patients. We have better to understand the culture, the value, the roles, so everything has to be really put in the context. We have to learn from other disciplines, anthropology, psychology, sociology, and really ask the patient or are the citizen, because what we often miss, that I did this as a mistake in the past. I just read the literature. Then I understood that I have to understand the context. So this is something enriching. Moreover, with the patients, it's not just to ask questions. We need to better understand self-efficacy, risk uncertainty. So all the elements who guide the person to the care, to the health, and everything. We are now working on. We have models now. So this is, in my opinion, moreover, not just association, but people. So we need to better offer the possibility to people to tell us, and we also are people. So again, also to ask the professional to learn also how to deal with different health literacy, because it's not just a translation issue. Also in my country, we use 3 languages, Italian, Latin, and German, and this was part of my study at the beginning, but then was not just a translation problem. People say, okay, we translate. Now we have also, for example, leaflet in only drawing, but drawing is not just a drawing issue, it's a mentality, what the concept you carry with this drawing. So I think I do not have a solution. We are working on this, but it's first of all to get from different disciplines information, ask people, and try to share together in order to better learn. So this is what we are doing.
Yes, I mean, in terms of the cultural issue, I presume you're talking about ethnicity as one of the key aspects of culture, but also perhaps other social groups, and probably both. Not an easy one, but I think you need to, well, I'm sure you do this work already, but you need to target the different groups. The difficulty, I think, is getting people to respond sometimes, as you know. Not so much with ethnic groups, I find, ethnic minority groups, but more some of the social groups, such as young men, for example, who are notoriously low responders to things. I say notoriously, perhaps that's a reflection of the way we don't seem to know how to communicate through these approaches. One of the methods which has been used quite successfully is sometimes called the hero model, where they look for peer leaders in those social groups. Not always easy to know who these people are, but anthropologists are very good at hanging out with such groups and start to identify the people who seem to have the respect of the others and use them as the kind of communication link within the group. And it might be in a very informal setting. not within the healthcare facility or something like that. In terms of ethnic groups, then I suppose what we often do is to work with those broader community groups. It might be the elders in the Bangladeshi society, or it might be, whoever it is that are seen to have respect and understanding. That's not to say what they say is necessarily what everyone thinks, of course. This is the difficulty. But at least it gives you some way into trying to understand how that culture responds to the kind of questions you've got and the kind of issues you're talking about. It's not going to give you... I'm not giving you all the answers, but some starting points maybe.
Not bad for 3 minutes, thank you. I think this might have to be our last question, and there's a lady over there who's been very patient. Can you get her the mic? Lovely.
I've got a mic here.
Can you stick your hand up again? Halfway up on the left.
Thank you very much, both teams, for the presentation. My name is Mebo, and I come from Uganda. My experience with working with patients, the few interactions that I have had with them is that patients prefer to remain silent. And then the other thing, for fear of being victimized and mistreatment from the health workers. And also the health workers, they have negative attitudes towards patients in terms of involvement. And they feel that patients are spies, they're spies on them, and they might lose their jobs when patients report certain problems in the system. So to the VU team, how did this happen? Were the health worker attitudes ready for patients being part of the team? And were patients ready to speak? I just want to know how this all started and happened. And then the other question is the implementation of ideas. How were the patients involved in implementing the ideas that actually gave to the hospital? And what was their role? What was their role in the implementation of the ideas that came out of that discussion? Thank you.
Thank you. So the first question, how do you get over that feeling of victimization and get the staff engaged?
Yes. Well, then you talk about the culture the professionals should have, or you want them to have in the hospital. I think for some methods it might not be a problem because they're anonymously for patients, like patiëntervaring.nl, the survey. So patients won't feel blocked to say what they want or to write down what they want. And for the other methods, like I take in the mirror interview, I think the selection of patients is already. Then you already have the ones who really want to speak out. So patients who are reluctant or don't dare to do that, they won't be the ones you will invite for the interview. So that's what you stress is it's a good point to think about. How can you reach every patient? Well, if that's possible, but we have, I think, in Holland, or if you can speak for the VU Medical Hospital, patients are not. Well, they are quite eager to say what they want, and they're not really afraid to do so. In generally, contrary, sometimes you think it might be a bit less, but you cannot say that, of course. But it's not. We don't experience it as a problem in our hospital.
Do you want to comment on the second point about how you then engage patients in the improvement?
And patients in implementation of ideas. That's a good one. I think we haven't reached that point yet. So you talk a bit about design, patient experience design, in which you include patients also in the improvements, implementation. I think we have to actively think about doing that more than we do now. So we can, until so far, we think we can implement the ideas ourselves. So thank you for this suggestion.
Would you, Piera, Andrew, want to comment on that?
Very quickly, in terms of the first point, I think my view is that you need to, I think the point has probably been made, that you need to engage the staff before you start to do some of these things. I know many years ago when I used to run a national patient perception survey, days before PICA, we used to be asked to run a survey, say, of hospital patient satisfaction. And my experience was that often you do this, and then people would ask you that difficult question at conferences, say, so what happened as a result? Not sure anything happened. Because the staff weren't in a position where they knew what to do with this kind of thing. It was just another report, tick the box, we've done it. And so one of the challenges I had, working particularly in this case with somebody in the Royal Marsden Hospital in those days, was to say, well, we'd like you to do the survey, but we don't want you to do it yet. We want the staff to be saying, wouldn't it be nice to know what the patients think about our services? And so they spent a whole year engaging the staff about quality issues and so on, to the point where they said, we really need to know what our patients think about what we do. And then was the point to say, well, there is something we can perhaps use here. Because then they were ready for it and wanted it. I think if you just impose it on people out of the blue, it's not going to work. There'll be resistance.
Great, thank you very much. If there are a few more questions, I'm sure the speakers will hang around for a few minutes to answer them. But I'd like to thank our 4 speakers very much, and I'd like to thank you, the audience, for some great questions. Please don't leave without filling in your evaluation forms, which are at the back. So thank you all very much indeed. Thank you. Thank you. It was great, very good. Thank you.